And I'd now like to invite Professor Rosner from the University of Virginia to talk about acute kidney injury and remind us that there are many other causes apart from ATN.
So thank you all for the invitation, especially to Ravi for being here. It's a great honor to talk to all of you and many friends. So the task ahead of me is really to remind you of some of the causes of acute kidney injury that are actually quite prevalent, but oftentimes we miss and forget about. So to anchor us, I'll just remind you of this famous song by Simple Minds, Don't You Forget About Me. Now, if you look at the history of this particular group, they've had probably about 60 members in the history of this group, and they still exist. But one must have been a nephrologist because they changed the lyrics of the song just so that they can remind us that within acute kidney injury, you need to think about other causes. Now, I will tell you, not only this is a song, it's a movie. It was the sequel to The Breakfast Club. Perhaps Ravi can invite me back next year to give you the ethical and moral implications of that movie for nephrologists, because they are actually quite profound. So, anchoring around this song, I will continue on. So let me give you a case. 59-year-old male, recent diagnosis of pancreatic cancer. He's gotten a gemcitabine-based chemotherapy regimen. During this therapy, he becomes neutropenic. He develops a fever, hypotension, respiratory failure. When he gets admitted to the ICU, he has a creatinine of 6.1, along with hyperkalemia, neutropenia, and thrombocytopenia. You are consulted for the diagnosis and management of his AKI. So what are the possible etiologies? Well, certainly acute tubular necrosis from this patient that looks like he's septic, certainly in the differential, but so are many other things. And this is just to remind you to begin thinking about those as we approach these patients, especially now that ICU patients are increasingly more complex, and in some ICUs around the country, 30–40% of patients may have underlying malignancies or being treated for a malignancy. So it's just not ATN. So clinicians in the ICU often equate AKI with limited etiologies and pathologies. Most commonly, those are ones associated with sepsis, nephrotoxins, volume depletion. Pathologically, we have a very heavy focus and bias on acute tubular necrosis. But increasingly, other etiologies and pathologies have to be considered and are coming, I think, more to the forefront. Especially true with patients with cancer and with autoimmune disorders, which we're again seeing more commonly, and the complex therapies that these patients are being exposed to. So some examples would be immune checkpoint inhibitors and interstitial nephritis, which I'm going to touch on, tumor infiltration as a cause of acute kidney injury, obstruction, thrombotic microangiopathies, which I'm going to spend a little bit of time on, light chain associated acute kidney injury, which can be an insidious but often present form of acute kidney injury, again, which I'll touch on, and then finally just a mention about some of the glomerular diseases that we can see in the ICU. So let's talk about immunotherapy-related acute kidney injury. Dr. Osterman gave a very nice lecture on this morning, but just as a reminder, immune checkpoint inhibitors, they've revolutionized the treatment of various solid and hematological malignancies, really quite a revolution in therapy. Now, these drugs block cytotoxic T lymphocyte-mediated tumor infiltration, and by doing so, they really allow a tumor response against an immune response against the tumor. Now, although those increased T-cell activation facilitates that anti-tumor response, it can also lead to immune-related adverse events. And the estimated incidence of acute kidney injury directly attributed to these agents is anywhere from about 2 to 5%. And the predominant lesion that we see on biopsy is acute interstitial nephritis, although glomerular diseases occasionally can be found as well. An important clinical point is that proton pump inhibitors are often in the background and may predispose to acute tubular interstitial nephritis through loss of tolerance from activation of drug-specific T cells, and therefore one of the first steps is always to discontinue these drugs in any patients with suspected AKI in the setting of these drugs. Secondly, a history of prior or concomitant extrarenal immune-related adverse effects, such as a rash, thyroiditis, colitis, should also raise our suspicion for an underlying acute kidney injury that's related to the immune-mediated mechanisms here. So here is the paper that I think has really anchored a lot of our thinking around this. This is a large multi-center international cohort study that looked at acute kidney injury in patients getting checkpoint inhibitors. 429 patients from around the world, and what they found, the clinical features were that the median exposure time was about 3 to 4 months. Extrarenal immune-related adverse effects were common, and the primary pathological lesion was acute tubular interstitial nephritis. The risk factors included PPI use with a significant odds ratio of 2.4, extrarenal immune effects, and then the patients that had worse starting GFRs were a slightly higher risk as well. Now, the treatment outcomes were relatively good, with recovery occurring in the vast majority of patients, and certainly early initiation of both stopping the agent and using corticosteroids certainly facilitated more early and more complete resolution. Now, re-challenge, interestingly enough, was not always associated with recurrence, but in about 16% that led to recurrence. Something that you can think about because these drugs are so effective for patients. You don't want to deny that use if you could possibly do that. So just one call for you to think about as this therapy is evolving and as we're seeing more complex patients getting multimodal chemotherapy. Just remember, and I highlighted it in the red box on this, if you're seeing patients with stage 2 or 3 AKI, and those patients have unusual features, significant amounts of proteinuria, hematuria, they don't respond quickly to stopping the drug and using corticosteroids, think about early biopsy. Because repeatedly, we have seen case series and other clinical experience has shown that glomerular lesions are particularly common in these patients. They can be easily missed, and they would change your therapy. So always think about biopsy in the patient that both has unusual characteristics and who may not be responding quickly to drug withdrawal and steroids. Just as a reminder, infiltrative disease of the kidneys causing acute kidney injury, not particularly common, but seen in hematological malignancies like lymphoma and leukemia, but something for us to think about again. And the key here is that when you're doing that ultrasound of the patient presenting with acute kidney injury, the kidneys are typically large, they may have a heterogeneous enhancement or echogenicity, but they are usually quite large, they look quite plump. If you have other imaging, you can also see that. And AKI likely results from the tumor cells causing tubular and vascular, microvascular compression impairing GFR. The key thing here is that when you start chemotherapy, this acute kidney injury resolves fairly rapidly. Once that intrarenal pressure begins to go down, those patients usually respond with improvements in urine output and GFR. However, these patients are at very high risk for tumor lysis syndrome, especially with the newer targeted agents and biologics, which are so effective at rapidly killing cells. We have seen a significant rise in tumor lysis syndrome in these patients with more effective therapies that really lead to cellular killing much, much rapidly. So I want to spend a little time on thrombotic microangiopathy because this is really an evolving field and one that I think is very complicated and difficult for clinicians sometimes to recognize and respond to rapidly. It's a spectrum of disorders between the two classical entities of typical thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. It can be associated with the cancer itself, I'll touch on that in a second, but more commonly with the chemotherapy or with patients getting stem cell transplant. Excessive conditioning regimens prior to their transplant can be associated with endothelial injury and the occurrence of thrombotic microangiopathy, as well as the drugs like calcineurin inhibitors that are used to prevent graft versus host disease. Although overall rare, they're really common causes of acute kidney injury in certain subtypes of patients. Indeed, when you look at the incidence of cancer drug-induced TMA during the last few decades, it's above 15%. And it's primarily due to the introduction of anti-VEGF vascular endothelial growth factor inhibitor agents. So whenever you see thrombocytopenia with a microangiopathic hemolytic anemia and no other alternate diagnosis, you want to think about a presumptive diagnosis of TMA. And again, we're going to divide those into three big buckets: cancer-associated, drug-associated, and stem cell transplant-associated. Within the drug-associated, it's important, very important, critically important to divide those into type 1 and type 2 disease. Type 2 disease has a characteristic appearance. It's associated only with VEGF inhibitors, and we'll come back to that. So cancer-associated TMA occurs in patients usually with solid tumors. The most common are adenocarcinomas of the breast, lung, and stomach, but also reported in a whole host of other cancers. The pathophysiology of this is completely a black box. It's thought that mucin-producing adenocarcinomas are producing a mucin that may exert a direct deleterious effect on endothelium or may interact with von Willebrand factor in some way to cause the thrombotic microangiopathy, but not at all clear. It can also be caused by activation of or occurrence of tumor emboli, which also can damage the endothelium. So really not clear, tends to be rare, also tends to be a diagnosis of exclusion when you don't have another drug that you can pin the TMA on. Now, drug-associated TMA is really where the money is and where more commonly this occurs. There's type 1 drug-induced TMA, which is due to microvascular thrombosis as the key event. It's not clear whether this results from direct endothelial toxicity or from an immune-mediated effect on the ADAM-TS13 metalloproteinase or other potential damaging activity. Many different chemotherapeutic agents, and I'm going to show you the list in a second, have been associated with this type 1 TMA. Type 2 TMA is only associated with VEGF inhibitors, whether they're receptor inhibitors, direct VEGF inhibitors, or tyrosine kinase inhibitors, where that pathway sits. Those really lead to new onset hypertension or exacerbation of pre-existing hypertension, acute kidney injury with some degree of proteinuria, and the histological features characteristic of a thrombotic microangiopathy. Now, of note, and what can be very insidious, is that about half the cases of that type 2 TMA are limited to the kidney without findings on the laboratory of microangiopathic hemolytic anemia. So you have to have a high degree of suspicion. If you're seeing a patient who's getting a VEGF inhibitor or a tyrosine kinase inhibitor, and they're developing acute kidney injury, hypertension, think about a TMA. Here's just some examples of that. Just remember that the vascular endothelium is really key, and one of the hallmarks of these drugs, the whole group of these drugs, which makes them very effective, is that they're going to inhibit angiogenesis. But in doing so, they can cause significant endothelial injury. They downregulate endothelial nitric oxide synthase, and all of those factors lead to injury, subsequent activation of pathways, and that thrombotic microangiopathy. So here's really the key takeaway slide, is when you think about anti-cancer drug-induced TMA divided into the type 1, which is due to typical chemotherapies like mitomycin C and gemcitabine being the commonest ones, like in the patient in this. It's typically delayed, occurs between 6 to 12 months after drug initiation. It's dose-related, but it's permanent. It tends not to be irreversible, and it will lead, unfortunately, to end-stage kidney disease and the need for dialysis in most cases. That's different from the type 2 that's associated with the VEGF pathway. Again, can occur here at any time, from a single dose up to 2-3 years later. It's not dose-related, but it's reversible. That hypertension, the renal function, tends to get better with drug withdrawal, and that's really the key. Now, just to move on, just touch on a couple other forms of acute kidney injury that you're going to see in the ICU that are not ATN, or light chain-associated acute kidney injury. Now, about half of the patients with multiple myeloma will have acute kidney injury sometime during their course of their disease, maybe due to the disease itself or, again, the therapies. But severe kidney failure generally occurs only about 1 to 3% of these patients. I'll show you the list of the different forms of acute kidney injury, and that's really shown here. Think about really the glomerular and tubular manifestations. We're not going to really talk about the glomerular manifestations. Those present as significant proteinuria, amyloidosis, nephrotic syndrome. It's really the tubular injury and that cast nephropathy that we're going to be concerned about that's going to really lead to acute kidney injury that you could see in an ICU setting. And really that proximal tubulopathy can be due to two things, either from the casts forming, big forms of concretions of those light chains, or those light chains being taken up by the proximal tubule, which are toxic to the proximal tubule and can cause injury. So it's really the intratubular cast formation that's so important. They precipitate in the tubules. That leads to acute kidney injury, lots of inflammation, lots of activation of inflammatory pathways. And really, one of the things that determines that is the particular physiochemical properties of that light chain that allows it to form those intratubular casts. Just a couple of things about diagnosis shown here. These are some clinical pearls. We typically do perform a kidney biopsy in patients who have an abnormal urine sediment and have a free light chain concentration that's pretty high or a predominance of albumin on a 24-hour urine. But we don't usually do a kidney biopsy on patients who have a bland urine sediment but have a very high free light chain burden, but a low urinary albumin concentration. Those patients, I think you can presume, because those free light chain assays are so good these days, that if you're not seeing proteinuria, you're seeing acute kidney injury, and you have a very high free light chain burden, you can assume that that's light chain cast nephropathy and go ahead and treat accordingly. Just to finish up, just to touch on rapidly progressive GN, again, these are rare patients, but you don't want to miss these in the ICU. These are not ATN. Think about really 4 groups: antiglomerular basement membrane patients, patients who have immune complex disease, patients who have vasculitis, and then an idiopathic group. Remember that kidney function impairment is going to be a present at diagnosis in most of these patients. They're going to come in oftentimes with multi-system diseases, including respiratory. The urinalysis really gives away the diagnosis. They have sort of dysmorphic red cells and red cell casts, and the marked reduction in glomerular filtration rate usually limits the rate of protein filtration, so these patients may or may not have significant amounts of protein. Lastly, never forget about obstruction. I'm not going to touch on this because I think everybody in the room doesn't miss this. That's why the ultrasound or other imaging is important, to have that as a high degree of suspicion. And really, just to summarize, acute kidney injury is a syndrome with a wide differential diagnosis. Various etiologies means different therapies with varying outcomes. You don't want to miss this. As our patient complexity increases, the likelihood that AKI is just simply ATN is going to become less and less likely. Systematic, disciplined approaches to diagnosis need to bring in other etiologies. And just to remind you about the song, "Will You Recognize Me? Call my name or walk on by. Hey, 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 whoa, whoa, whoa." So you did not want me to sing. So thank you very much.